Hi. Today, we will be discussing Chapter 28 of Harrison's Principles of Internal Medicine. This chapter deals with disorders of the eye. In this slide set, we will discuss eye disorders that cause proptosis. Proptosis is defined as an abnormal protrusion of the eyeballs. The term is often used interchangeably with exophthalmos, which means the same thing. The position of the eyes within the orbits is measured by using a Hertel exophthalmometer, a handheld instrument that records the position of the anterior corneal surface relative to the lateral orbital rim. The development of proptosis implies a space-occupying lesion in the orbit and usually warrants a CT or MR imaging. In this set of slides, we will discuss 5 etiologies, namely Graves' ophthalmopathy, orbital pseudotumor, orbital cellulitis, tumors, and carotid cavernous fistula. Graves' ophthalmopathy is the leading cause of proptosis in adults. The proptosis is often asymmetric and can even appear to be unilateral. Orbital inflammation and engorgement of the extraocular muscles, particularly the medial rectus and the inferior rectus, account for the protrusion of the globe. Corneal exposure, lid retraction, lid lag on down gaze, conjunctival injection, restriction of gaze, diplopia, and visual loss from optic nerve compression are cardinal symptoms. Graves' eye disease is a clinical diagnosis, but laboratory testing can be useful. The serum level of thyroid-stimulating immunoglobulins is often elevated. Orbital imaging usually reveals enlarged extraocular eye muscles, but not always. Graves' ophthalmopathy can be treated with oral prednisone at 60 milligrams per day for 1 month, followed by a taper over several months. Orbital pseudotumor is an idiopathic inflammatory orbital syndrome that is distinguished from Graves' ophthalmopathy by the prominent complaint of pain. Other symptoms include diplopia, ptosis, proptosis, and orbital congestion. Imaging often shows swollen eye muscles with enlarged tendons. The diagnosis of orbital pseudotumor is difficult. A dramatic response to a therapeutic trial of systemic glucocorticoids indirectly provides the best confirmation of the diagnosis. Biopsy of the orbit frequently yields non-specific evidence of fat infiltration by lymphocytes, plasma cells, and eosinophils. Orbital cellulitis causes pain, lid erythema, proptosis, conjunctival chemosis, restricted motility, decreased acuity, afferent pupillary defect, fever, and leukocytosis. It often arises from the paranasal sinuses, especially by contiguous spread of infection from the ethmoid sinus through the lamina papyracea of the medial orbit. A history of recent upper respiratory tract infection, chronic sinusitis, thick mucus secretions, or dental disease is significant in any patient with suspected orbital cellulitis. Most patients respond to empirical therapy with broad-spectrum IV antibiotics that includes coverage of methicillin-resistant Staphylococcus aureus. Occasionally, orbital cellulitis follows an overwhelming course with massive proptosis, blindness, septic cavernous sinus thrombosis, and meningitis. Prompt surgical drainage of an orbital abscess or paranasal sinusitis is indicated if optic nerve function deteriorates despite antibiotics. Tumors of the orbit cause painless, progressive proptosis. The most common primary tumors are the following: Metastatic tumor to the orbit occurs frequently in breast carcinoma, lung carcinoma, and lymphoma. Diagnosis by fine needle aspiration followed by urgent radiation therapy sometimes can preserve vision. In cases of carotid cavernous fistulas with anterior drainage through the orbit, these fistulas produce proptosis, diplopia, glaucoma, and corkscrew arterialized conjunctival vessels. Direct fistulas usually result from trauma. They are easily diagnosed because of the prominent signs produced by high flow, high pressure shunting. Indirect fistulas or dural arteriovenous malformations are more likely to occur spontaneously, especially in older women. The signs are more subtle and the diagnosis frequently is missed. A bruit heard upon auscultation of the head or reported by the patient is a valuable diagnostic clue. Imaging shows an enlarged superior ophthalmic vein in the orbits. Carotid cavernous shunts can be eliminated by intravascular embolization. This ends the discussion on proptosis. Next set of slides will discuss disorders that cause ptosis.